I'll introduce you to Dr. Susan Massengill, a clinical and research pediatric nephrologist at Levine Children's Hospital in Charlotte, North Carolina. Named a Best Doctor in America for the past 21 years, she has published more than 60 articles and abstracts concerning several renal diseases. In addition to being a NephCure specialist and serving the professional community of nephrologists, Dr. Massengill is on the medical advisory board of the Lupus Foundation and is a member of the board of directors of the National Kidney Foundation of North Carolina. All right, she's going to get started and share some of her slides with you. And if you have any questions, feel free to put it in the chat and we'll get to them at the end. All right.
You ready?
Yep, we are ready.
So I'd really like to thank NephCure for giving me the opportunity to spend the next, 45 to 60 minutes with you guys about something that's very near and dear to my heart, which is nephrotic syndrome. I've told many patients and families lately, I'm as hopeful about nephrotic syndrome as I have been in many years and think we are finally moving in the right direction. So my task is to talk to you today, parents and patients of newly diagnosed nephrotic syndrome. This is mostly geared toward pediatrics, but I think it's applicable to others as well. So these are my dear ones. Many of us have had children that look like this. And so this is just some of the peripheral edema. I think there's nothing cuter than these kids when I first meet them. It's not so cute to y'all, but it at least allows us to know where we're heading and where we can go from there. So I'd like to touch a little bit on the science to clarify what glomerular disease is. So the glomerulus which is a filter in the kidney, and I describe it similarly to a filter in a car. You know, its job is to filter the blood of the impurities. Blood comes in through this artery, goes through this process with blood being filtered. The filtrate comes out, which is what you're seeing here, and then the rest of the blood goes back through the vein. And glomerular disease in general is a term that just describes abnormalities of this filter. And each one of our kidneys has about 1 million filters. And causes which can affect these glomeruli can either be immune mediated, it can be idiopathic, which is a lot of what we deal with in the pediatric population, or there can be some genetic causes as well. So when you look at this particular, this is one of the, I'm trying to use 2 screens. This is one of those filters. And when we magnify it up, this is what the part of the glomerulus looks like. And this is what's called a podocyte. It's like a little octopus-like cells that contain those filtration barriers. And we'll talk a little bit about that in a minute. And then there's foot processes, which are these little things that extend from that podocyte and wrap around that capillary wall, and it forms these little filtration slits in here. And so it's just, and this is that area that will get primarily affected. And these podocytes are like little finger-like projections that again wrap around and interdigitate. And when we talk about it in a little bit, these are some of the areas whereby some of the genetic mutations can occur. And without going into too much detail, each form of a glomerular disease impacts the glomerulus very differently. Some can cause there to be an overproduction of antibodies. Some can disrupt parts of this filter or this glomerulus, and others can impact what's called the basement membrane, which is this part here. This is just another little cartoon that I particularly like. This is that glomerular basement membrane that we talked about. These are those little finger-like projections, and they're some molecules that kind of keep them sitting on that glomerular basement membrane. And here's that little slit that I was talking about. And this is the blood side. And then what will happen is in nephrotic syndrome, particularly minimal change and FSGS, this foot process, it just kind of melts and it loses some of its integrity. And this is what we'll call effacement. And if any of you have ever looked at your child's biopsy, you'll see mild effacement, 100%, or global effacement. And that's what they're talking about. And then eventually, as disease continues, some of these podocytes actually fall off. And once they fall off, they're not able to be regenerated. And when you have this disruption, so here it's a pretty tight slit where it obstructs bigger molecules from going out, one of those being albumin. But when this area is disrupted, you can see that now protein can leak out of that and go into what we call the glomerular space, or it leaks out into their protein. The other thing that I try to tell people is when these proteins stay in the blood space, it acts like a sponge. And when there's a sponge, it holds the fluid within the blood space. And when your child has a relapse or first presents, because there's some leakage of that sponge into, or the albumin into the urine space, that sponge effect is lost. And that's why fluid leaks out into your child's face and belly and private areas and their lower legs. And so that's just, it's kind of a little bit of a pictograph that I like that explains that a little bit better. So let's talk a little bit about primary nephrotic syndrome. The epidemiology, at least in North America, and we're primarily talking about North America today, the incidence is in about 2 to 7 per 100,000 children. The peak ages in our school children, so usually between 2 and 6 years of age, with 80% of children presenting at less than 6 years of age with their primary nephrotic syndrome. There's a male predominance, albeit slight, and this predominance is lost as one goes towards adolescence and it becomes more equalized. There's a predominance of Blacks and Latinx patients compared to white patients in North America. And there is a small familial chance of nephrotic syndrome between 2 to 8%. To show you how infrequent it is, I've been doing this for over 20 years. I've never had a family with familial nephrotic syndrome. And I've seen a lot of nephrotics. When you think about the classification of nephrotic syndrome, we categorize it as primary nephrotic syndrome, secondary nephrotic syndrome, and then congenital and infantile nephrotic syndrome. I'm not going to spend a lot of time on either one of these. I will touch on them a little bit, but majority of this talk is going to be on the primary nephrotic syndrome. So when we think about primary nephrotic syndrome, and NephCure does this better than anybody, you've seen their pictures where they've got the umbrella, and then coming out of the umbrella, above the umbrella is just a global concept of nephrotic syndrome, but each one of those little spokes can be a different type of nephrotic syndrome. And in the childhood population, 77% of children with nephrotic syndrome, when they present, have minimal change nephrotic syndrome. Less common, although still seen, can be membrane proliferative, which presents usually a little bit different. Focal segmental glomerulosclerosis, which we'll touch on more in this conversation, which is everybody's nightmare at times. Proliferative glomerulonephritis, and proliferative just means that there's more cells there that generally need to be, and that usually occurs in that area around where that filter was. Massengill proliferation, and then much more uncommon in the pediatric world is membranous nephropathy, which we do see. And in fact, we had an increased number of this a couple of years ago. If you look, the other key feature in this is in children. So if you were looking at a diagram from childhood to adulthood, from adulthood down, in children, again, almost all nephrotic syndrome is going to be minimal change. As you start approaching early adolescence, late adolescence, or into adulthood, now the most common cause of nephrotic syndrome is going to be membranous nephropathy, with FSGS falling close behind. There's been a little bit of shift in that over the last couple of years. So when one looks at the classic triad of nephrotic syndrome, first and foremost, we generally see edema, which is also called swelling. There can be a low albumin in the low protein in the bloodstream, and you may hear your nephrologist say hypoalbuminemia. Hypo means low. And then there's high albumin or protein in the urine, which is called proteinuria. And very infrequently, although in about 25% of kids with nephrotic syndrome will have hematuria and or some hypertension on presentation. So this is our friend, the glomerulus, and this is a very normal appearing glomerulus, or one of those filters in the kidney. And these are one of those little loops that we were talking about, and where the podocytes would rest on this. And you can see it's just pretty wispy. There's not a lot of activity. It doesn't look very crowded. And so, as we talked a minute ago, minimal changes most likely to occur in those children who are less than 6 years of age. They have an absence of hypertension, an absence of hematuria or blood in their urine. Their complement levels are normal, which are some proteins in your bloodstream that when your immune system gets really revved up or jazzed up or whatever, we see that in lupus, we see it in that some of those proliferative lesions. They're generally normal in children with nephrotic syndrome, and they generally have very normal kidney function. Although we have seen more and more literature to support that about 20 to 25% of children with minimal change disease can have some degree of altered function. I've got two children in the hospital right now that have some acute kidney failure as a result of a relapse with their nephrotic syndrome. So not common, but not infrequent. So let's talk a little bit about, your child has come in, they've been diagnosed based on their lab studies and their urine studies, and we know that they've got nephrotic syndrome. Because of studies that were done back in the 70s through the International Study of Kidney Diseases in Children, or what's also called ISKDC, we know that of children who present in that age group we talked about between 2 and 6 years of age, 90% of those children, or 9 out of 10 children, are going to have minimal change nephrotic syndrome. And as a result of that, and that was determined through multiple biopsies and following children. But as a result of that, knowing that 9 out of 10 children are going to have minimal change disease, we no longer go to a biopsy right out of the gate like we used to. And so if you fall out of that range, so if you're less than 1 year of age, or you're 12 to 14 years old, you've got pretty significant hypertension, you've got visible blood in your urine, which we call gross hematuria, or those complement studies that we talked about are abnormal, or there's just something else that's just a little out of sorts, those children will go on to a biopsy. But by and far, the majority of children who present with new onset nephrotic syndrome will not get a biopsy. That being said, about 90% of those same children who should have minimal change disease are going to be steroid sensitive. And so for that reason, we will initially start children on prednisone, what we call 2 milligrams per kilo, or 60 milligrams max, where they'll be on that for 6 weeks. There are a few derivations in how people treat. When I initially started many moons ago, we would do 4 weeks of daily and then 4 weeks of every other day. There is some newer literature to support that perhaps if we did 6 and 6, that the relapses that these children have are less frequent. But so we go 6 weeks of daily prednisone, and then we switch to 6 weeks of every other day prednisone, which occurs at a much lower, it's at a lower dose. And then there's discontinuation. In my practice, one of the things that I've started talking to parents about is I say, your child's got 3 tests. So test 1 is, do they or do they not respond to steroids? And most of these children will respond to steroids within about 7 to 10 days. And we'll talk about it a little bit later if they don't. Some take up to a month, but by and far, most kids will show an improvement in their urinary protein within about 7 to 10 days of starting prednisone. So for me, test 1 is, do you or do you not respond to steroids? At the end of that 6 weeks, we're going to go to every other day, and that's test 2. And I've tried to make it as simple as I can for the family. So test 2 is, when you get to every other day prednisone at a reduced dose, do you stay negative with your urine protein monitoring? And so then we stay there for 6 weeks. So test 3 is, at the end of those total 12 weeks, is your child still negative? And once we stop, do they stay negative? And I have just found that families kind of understand. They'll come in, I'll say, oh, you passed test 1. Okay, we're going to go to test 2. You passed test 2. And we kind of go that. And I also am one who, I tend to be the optimistic person. I try to tell the family, the chances of your child having minimal change disease is 90%. So let's just stay right there. If we need to get what the other 10% might be, we'll go there. But if you're never going to get there, it's probably not worth reading and learning all these terrible things that people find if you're never going to get to that point. So this is our initial treatment that we do in the pediatric world. So I thought I would give you a few definitions to help you, because you're going to hear a lot of this verbiage. So we just talked a little bit about steroid sensitive, and that is they respond, and they usually will respond within 7 to 10 days, definitely by a month. Sometimes we'll give them a little bit longer. Steroid resistant nephrotic syndrome is defined as nephrotic syndrome that is not responding to steroid therapy. And that's defined by the absence. You're not seeing a diminishing of the serum of the urine protein, or their blood studies are not normalizing. A complete remission is when you're monitoring their urine protein and you see it being totally void of any urinary protein. We generally do that on first morning urine protein because that's the most reflective. I consider trace and negative about the same thing. And so we give our families urine dipsticks that they're going to monitor their child's urine first thing every morning and monitor and watch and see how that's going. A partial remission is a decrease in the proteinuria, but they just aren't quite there yet. Maybe they're staying at 1, maybe they're staying at 2+, but generally it's not your 3 and 4+, and really don't see a lot of edema with it. And then relapse is a word that we use that talks about the recurrence of the urine protein. So they went into remission, they had no urinary protein on monitoring, but now suddenly their child gets a cold, something's not right, and they start seeing that the protein is coming back. And that's what we call a clinical relapse in nephrotic syndrome. So here's some other terminology that you might hear. These are patterns of response, and we'll talk about a little bit of these in a second in further detail. There's steroid responsiveness, and that just purely means your child is responding to the steroids that their doctor has put them on. 80% of children are going to show an initial steroid responsiveness. That means within about 7 to 10 days, 2 weeks, their urinary protein is going to go negative. We'll talk a little bit about the frequently relapsing or steroid dependent children. And then there's a late steroid resistance, which occurs in about 20% of patients. So about 80% of patients, 80 to 90% are going to be steroid responsive. And then there's about 20% of the patients that will be steroid resistant. So let's go back to steroid responsiveness. You can have an initial or infrequent relapse, and we just talked about that a little bit. You're going to go into remission. Your urinary protein is going to go negative. And usually, and this is if they've had a relapse, we'll put them back on steroids. We'll ask our families to monitor the urine protein. And when you see it go down, when it's negative or trace for 3 to 5 days, then generally we will take your child to every other day prednisone for about a month, and then we'll discontinue it. And so in most children will experience a relapse. So it can either be just an infrequent, or they can be one of these children that develop a frequently relapsing pattern. And that occurs in about 25 to 30% of children who are steroid sensitive. And it can occur with tapering. It can occur soon after they get off of the prednisone. They may be in preschool or school and they're having frequent infections. Not seen many. I was just telling Rachel earlier, we have not seen a lot of infections this year because everybody's been masked and not in school. But so again, it's not very common, but there is a good percentage of patients who will have a frequently relapsing course. And by definition, that is 4 relapses within a year or 2 within 6 months. And then there's the steroid dependent pattern. Sometimes it's a little hard to, depending on how people choose to treat, distinguishing between that frequently relapsing and that steroid dependent. But by definition, steroid dependent is that patient who has relapsed during a taper or within 2 weeks of discontinuation of steroids. So let's talk a little bit about prednisone, everybody's friend and enemy, unfortunately. So prednisone acts to decrease inflammation within the kidney. Not exactly sure why that happens. And so the exact nature of its working is unknown, but we certainly know it does. And it has been a game changer for many of our kidney conditions prior to the use of prednisone back in the 60s. The outcomes for nephrotic syndrome were much worse. And after your child has been put on prednisone, the first thing I will tell families, even before you start seeing their urinary protein decline, you're going to see them like they're going to start going to the bathroom like crazy. Some of our younger kids, our toddlers who are not bedwetters, sometimes they'll even have bedwetting as a result of them going through this brisk diuresis or brisk loss of all the extra fluid that has been collected. The next thing that you're generally going to see if you're monitoring at home is you're going to see that their urine protein is going to normalize. And as I said earlier, about 7 to 10 days, and sometimes by 80% by 14 days. The very last thing to normalize, and why we always don't do a lot of blood studies in your first visit or two back, is that blood protein or the blood albumin is the last thing to normalize, and that usually takes about a month. The one thing I didn't mention earlier that some of y'all might know is when they present or when they're in relapse, they can have what we call hyperlipidemia, or their cholesterol levels are quite high, and it's not because of what they're eating. As the liver is trying to crank out more albumin, it doesn't distinguish between other proteins. So it also tries to kick out other proteins, and cholesterol is one of those. And so it's making more albumin, it's making more cholesterol, and that's why many of these kids have elevated cholesterol. So let's talk a minute about the side effects of prednisone. And again, prednisone is a great medicine for those of us that live in our kidney world, but they're not without consequences. I've started telling families, I've been doing this a long time. I've stopped trying to predict how someone is going to react to prednisone. I had a boss when I was in fellowship who was on steroids for a kidney condition. And the joke was, is this a good day or is this a bad day? My personal view is it sometimes just takes their inherent personality and ramps it up a little bit. And then there's always those that are at the other end of the spectrum. I've had kids giggle the whole time they've been on prednisone. And then I've had others that you really wanted to lock in a closet. And so from parents' perspective, things to think about is increased blood pressure, not uncommon, particularly in the beginning of treatment. Sometimes requires use of blood pressure medicine, but not often. The hunger for kids who are not big eaters, sometimes you will see them, they almost want to eat you out of house and home. And it's a hunger that many parents have never experienced. I tried, and it's been harder. We've seen a lot of weight gain for a lot of reasons during this pandemic. I try to encourage families to try to keep their eating at mealtime and try to do portion control. If you give them a giant bag of potato chips, they're going to eat a giant bag of potato chips. I tend to encourage families to make little teeny snack bags with a couple, 4 or 5 chips in it, some type of thing that they like. Sometimes it's just getting the taste and the crunch that suffices that craving. Same thing with sugar. If you give them a king size Milky Way bar, they're going to eat the whole thing. But if you give them a couple of those little bite-sized things, again, it helps that craving. Other things you can do, fruits and vegetables, an apple. Similarly, by the time they finish eating the apple, kind of that craving has gone. And just try to limit the grazing all day long. I've seen kids gain 5 pounds. I've seen kids gain 25 pounds on prednisone. The other thing that you will notice, and you've gotten a little bit used to the puffiness in the face, and it takes a while for that to come, and then it kind of goes away quickly. And the next thing we'll hear is, oh, my child's swelling again because their face is puffy. That's called a cushingoid appearance from the steroids. It kind of gives them this fullness to their face. It's a different fullness than you see when they presented or when they're in relapse. They're not going to have the same swelling around their eyes or the pitting edema in their lower legs or things like that. It's just, and it comes, and then as we get them off prednisone, it tends to go away. Prednisone, your kidneys. So if you can go back to that picture I was telling you about, as the blood is coming, you've got blood that comes into that filter and blood that goes out. When the kidney perceives the blood it's not getting its full share because it's leaked out again because that sponge is not there, then the kidney is going to crank out a few hormones that cause the kidney to hold on to salt and water. And that and prednisone does the same thing. So you can see that the swelling can worsen. So that's one of the reasons we try to put these children on a low sodium diet, which they hate. and we can talk about that too in a little bit, but toddlers in particularly do not like a low salt diet, because what do toddlers like to eat? Hot dogs, chips, cheese, mac and cheese, pizza. Each and every one of those is very high in salt, and the more salt they have, the more fluid that they hold on to. Prednisone can make them somewhat more susceptible to infection, but I'll allude to this a little bit later. Their nephrotic syndrome on its own already puts them at tremendous risk for infection. So this actually is a benefit to get them under control. Again, I've been doing this a long time. I do not generally see a lot of children get bad infections on prednisone. A rare complication is called avascular necrosis of the hips, and generally that occurs in people who have been on long-standing, frequent, or maintenance prednisone. I have seen it rarely, and mostly in other things outside of nephrotic syndrome. Mood swings, again, this is a biggie, particularly for the toddler and the adolescent. And I joke with the families, if they couldn't hit their sibling yesterday, they can't hit their sibling today. If they're a hyperactive kid, they might be a little bit more hyperactive. If they're irritable and a grouch, they're going to be grouchier. They could be happy. And so I tell kids and tell families all the time, you get a self timeout. It's easier to do that in the older kids. And, and I'll tell the older kids, you don't have to like this, but at least you can understand that your mood's going to be a little edgy and that you might be 1 minute happy. Just remove yourself from that situation. Say, I need a timeout, go outside, go to your room. Equally, parents can tell the older kid, go to your room, go outside, just separate yourself. The toddler, it's a little bit harder. A toddler's already trying to establish their independence anyway. They don't like being told no on a good day, and they certainly don't want to be told no on a day of prednisone. And so just trying to divert their attention, and usually the mood swings are they come and they go about as quick as they come. And so just trying to use some of those tactics. I'll tell families, you may have to count to 100 instead of 10. Find out what sibling pushes their button and try to kind of take care of that and alert them to things. And again, trying to find that balance. If you let them get away with murder and they continue to get out of murder and you're feeling really sorry for them, you can absolutely create a monster. And I've dealt with many families who are like, gosh, we should have done something about this a long time ago. GE reflux, sorry, I put GERD. Unusual, a little bit of heartburn. Some people will get that on steroids. We encourage people to take the prednisone in the morning on not on an empty stomach, but with some food in their stomach, even if it's just a little bit of toast or a little bit of yogurt. Subcapsular cataracts are a late finding of nephrotic syndrome. And again, usually occurs in those who have been on steroids for a much longer period of time. Oops, sorry. And then the girls can get some menstrual irregularities. The older kids, and particularly the adolescents, this is it. They don't like the acne and they don't like the swollen face. All those will go away as you discontinue the prednisone, but it definitely is a problem in some. Not everybody gets acne. So let's talk a little bit about second line therapy. So, and we're still in those children, we're still in the category of those children that are steroid responsive, whether it be frequently relapsing or whether it be the steroid dependent group, but they still show that they've got a steroid response because of all the things that I just mentioned, and all the potential side effects that can occur with respect to prednisone. Sometimes you got to move on. Again, I think steroids are great, but they're not good to live on forever. So agents that if you've got someone who is steroid sensitive, we may try the two agents. The oldest one that we have the most literature on is on cyclophosphamide. If you live up north, sometimes they will use a medicine called chlorambucil. And these are an alkylating agents. This medicine, 56 doses for 8 weeks. Give it in the morning. It's not as easy to give in the younger child and finding someone to compound it. And then the new one to the club, this one is not larger than this one for any particular reason other than that was a mistake. Mycophenolate mofetil, or MMF, also called Cellcept, is one of our newer agents that we've used for those that are steroid sensitive. It's one of our mainstays in our kidney transplant patients. It's generally very well tolerated. It tastes good. It comes in a liquid form as well as pill form. It generally is well tolerated, but it's a much longer course. And so kids will be on this for usually over a year. It's an every 12-hour dosage, as opposed to this one, which is for 56 doses. When I have families come in, I offer both. I think both are effective. Doing one before the other does not preclude ever using the other one. I would say by and far most places now are using mycophenolate mofetil and not using cyclophosphamide. I try to give families the options, weigh the pros and cons. Some families are very hesitant to be committed to a medicine for over a year. Some are terrified by some of the potential complications of cyclophosphamide. So again, I kind of have that conversation with the family and have them share in that decision. If you are a steroid resistant pattern, we're going to talk about that a little bit later too. We often will use what are called calcineurin inhibitors. And probably the latest and greatest is rituximab, which is a chimeric anti-CD20 monoclonal antibody. That's a fancy term for an antibody that actually attaches to one of the B cells that seems to have become very effective in those patients that are steroid sensitive and on steroids a lot. It is probably now a third line. It would not surprise me if it doesn't change in its lineage. And then there are rare times where I have been at a loss for anything and have used it in some of my steroid resistant or kids who are on multiple medications, and it too can be effective. So these are generally CellCept, cyclophosphamide, and rituximab are ones we will use for steroid sensitive, frequently relapsing or steroid dependent children. Other treatments we talked about a little bit, sodium restriction, which is very important in the early stages. Some of your children will be admitted to the hospital and may get some of that albumin, which is that protein that they're losing in their urine, the quote sponge that we give back. And when we give it to them, it pulls some of that fluid in, and then we're able to give them some diuretics to get rid of that fluid. So it's this cycle that we do to get them ready for discharge. So you come to clinic, your child's been on prednisone for about 4 to 6 weeks, and they're still swollen and the protein is still present in their urine. Doc, what does this mean? You told me that 90% of children are not, that there was a great chance that my child was going to go into remission on with steroids. So now we're concerned about steroid resistance. And this is defined by the absence of a complete remission. Again, remission means they don't have any urinary protein when you do it by dipstick or your doctor looks at it in the office after 4, sometimes we'll say 6 weeks of daily prednisone. And this occurs in about 10 to 20% of patients who develop nephrotic syndrome. And then about of that 20%, about a third of them are going to have what's called steroid resistance due to some gene mutation that can affect that podocyte, which is that little thing that we saw. I think I've got a picture of it again in a second, or those little finger-like projections. And we'll talk a little bit about those in a minute. I'm not going to go into great detail about every genetic mutation, but just know that that can occur particularly in the face of steroid resistance. If the child has a genetic form, or adult for that matter, has a genetic form of a steroid resistant nephrotic syndrome, then we're not going to use all these medicines that we just talked about because they're not going to do any good. We're going to use other types of therapy to hopefully lessen or somewhat cut the protein losses that they're having. But usually the disease progression in this population of patients is pretty aggressive. But if there is a light at the end of the tunnel, when you talk about all this, the risk of recurrence in a transplant is very, very low compared to what we see in other populations. So we talked about minimal change disease with steroid sensitivity, frequently relapsing condition, or steroid dependent. Now we're going to talk about focal segmental glomerulosclerosis, which for our world is the next most common thing. Again, this and this are more predominant in the adult population. For us, if it's not this, generally it's gonna be FSGS. So when you have steroid resistant nephrotic syndrome, we talked a little bit earlier about who gets a biopsy and who doesn't. We talked a little bit about age, or being, if they're if they're less than 1 or greater than 12 to 13, if they've got some severe hypertension or acute kidney injury or some of the other things. Those are the kids that are going to get a biopsy, the steroid resistant, or if you have some suspicion that they might have some genetic mutation that's leading to their steroid resistance. These are our friends, the glomeruli again. And again, this is that glomerulus that's got these are capillary loops, and they're kind of thin and wispy and not seeing a lot of activity in here. And this is just an example of what's called focal segmental glomerulosclerosis. And you can see here a little bit more in, a little bit more in here. This is scarring, and this is what we call that focal, in that it's not the whole glomerulus, but it's a focal part of it, and it's scarring down. And you can see it's just in this area. And this is just classic FSGS. And then you also sometimes see some shrinkage of some of the tubules, or what we call tubular atrophy, which is another marker that we'll see in this type of scarring nephrotic syndrome. I told you I'm not going to spend a lot of time on genetic causes of steroid resistance, but they can occur in parts of the podocyte or the slit diaphragm. And so it can be, you'll see that there can be a mutation in nephrin. There can be a mutation in podocin. These are both associated with focal segmental glomerulosclerosis. This one, the nephrin, causes a thing called congenital nephrotic syndrome, which is beyond the scope of this talk. And that's generally going to be in that child who's an infant, that we'll either know before they're born, or we'll know shortly after birth, or within the year that they've got nephrotic syndrome. There can be, you can see that many of these are associated with FSGS actinin. A rare condition is called Denny's-Drash syndrome. We've actually had 2 in the last couple of years. It is a defect in a Wilms tumor gene, and Wilms tumor is a tumor that can affect the kidney. So children who have, this often is in that younger child also, but when they present, ultimately we will do what we call bilateral nephrectomies, or take out both of their kidneys because of the risk of them developing a Wilms tumor that needs chemotherapy, put them on dialysis, and then get them old enough to undergo kidney transplant. Actually have one I'm working up for that right now. And then another one that often presents in children is a mutation in laminin, and that's a thing that's called Pearson syndrome. To give you a little bit more of a perspective, you've got about a 70% chance of having a genetic mutation if you're under 3, 50% if you're under 1 year of age. If you're steroid resistant and you're greater than 2 and less than 6, about a 25% chance. And then the older you get into adolescence, it's more 10 to 15% chance that you might have a genetic form of nephrotic syndrome. This is just to kind of go back and that picture that I showed earlier, and showed that some of those mutations, the podocin, so there can be a mutation in proteins that work with this, and then there can be some mutations in those little slit diaphragms. And so just to kind of take you back to where it is in the glomerulus that can be affected. Now, I mentioned that we're not going, and those are all primary forms of nephrotic syndrome. I wasn't going to spend a lot of time talking about secondary forms of nephrotic syndrome, which aren't nearly as common in children. There can be some viral associated. I've had a child that had a thing called congenital CMV, or cytomegalovirus, who got nephrotic syndrome. Again, not common. There are some rare medications that can cause nephrotic syndrome. And then there can be what we call adaptive, and that can be either from reduced kidney mass, so what we see in premature babies. So if a baby is born at 24 to 26 weeks of age, they do not yet have all the full complement of filters, because you continue to grow filters, for lack of a better word, or the kidney continues to mature until about 32 to 33 weeks of gestation. So if you are born at 24 to 25 weeks, you're not going to get more filters. You get the filters that you have. And so as you get older, you are not going to have the full complement of filters that a normal child who's born at term has. Compound that by some of our children who are born premature and who have only one kidney. It's a double whammy because, and I've got a couple of kids who have gone on later to have issues as a result of that. And then it may be that they initially had kidneys that were normal in size and got a full complement, but something has caused those filters or those glomeruli to be taxed. That can be obesity, it can be severe hypertension, it can be other types of things that make those filters kind of work overtime. Similar, it's just like the car filter. You know, they just, if it has to work overtime and do extra things, eventually some of those are going to burn out. So those are what we call maladaptive forms of secondary FSGS. So what do we do about this steroid resistant nephrotic syndrome, and how do we manage them? If you've identified, and again, depending on the age of your child and whether your nephrologist is recommended to get genetic testing, and make sure they get you the approval of your insurance company. These tests are not cheap. I think it's getting easier and easier to get those, particularly because we can direct therapy a little bit different. But if you don't want to get a $4,000 to $5,000 bill, just make sure that it's been cleared by your insurance company that you can get this testing done. But if you have a genetic cause of your nephrotic syndrome, then you're not going to go on all these medicines that we talked about, and you're going to use what we call an angiotensin converting enzyme inhibitor or angiotensin receptor blockade agent. So these are your prils like enalapril, lisinopril, ramipril, and then your ARB agents are your TANs. The most frequent one that we use in pediatrics is probably losartan. So these are, because immunosuppressive therapy or therapy that suppresses your immune system is not going to do you any good, we're not going to put you on these. If you have non-genetic causes, then almost everybody's going to be on these. And some of the newer studies that are coming out, and there's a new study getting ready to open up in younger kids, there are some agents that are combining an ACE inhibitor, an ARB agent with another agent that affects the blood vessels and is felt to be helpful in reducing proteinuria. And then we may put you on a medicine called cyclosporin or tacrolimus. Those are called calcineurin inhibitors. Most of the data that's been done is around cyclosporin. Great medicine, not well tolerated by a lot of, it tastes awful. It can cause some hairiness. Teenagers don't like it very well. Tacrolimus has had, which many of us use, there's still very much a cyclosporin camp. Tacrolimus is easy to take. The complications are limited. It tastes good. Much easier to get the, I think it's much easier to have adherence or compliance with. But both are acceptable. Let's talk about, and again, sorry, I have used rituximab in this group and have had resistance a couple of times, not universally, but at times. So let's talk a little bit about relapses. And again, relapse is your child's had negative protein in their urine, and now they are starting to, I've gotten 5 calls this weekend. My child is spilling a little bit of protein. They've had a cold, or I don't know what's going on. Their allergies are crazy. They're not swelling yet. What do you want me to do? So about 1/3 of all children will have at least one relapse. 1/3 will relapse intermittently. About 1/3 will become steroid dependent. And there is a population that continues to relapse and they don't outgrow it in childhood. I took care of, when I was in fellowship, we took care of a faculty member's child who was in her 30s who relapsed about every 5 years. And then the rest of the time she was fine. With respect to FSGS, about 1/3 will evolve with FSGS and they'll maintain their kidney function. So they just kind of, they're not always nephrotic. They're doing okay. About 30 to 40% will progress to end-stage kidney disease. And that means they're on dialysis in need of a kidney transplant. And perhaps the most frustrating thing that we ever deal with is the chance of recurrence after transplant, which can occur in about 25% of patients. I have to say, in my experience, it's not been that high, but it is one of the most frustrating things that we deal with. And it can literally happen within the operating room, and we think it has to do with some type of a circulating protein that we're still trying to better define. So I thought I'd spend a little bit of moment on when should you be worried. So back my initial conversation with parents in the beginning years, these are the 3 tests, and kind of talk them through about that, talk to them about some of the side effects of prednisone, and then what needs to happen and when do you need to call me. And I figured that's enough to get in the first interaction with me. So if your child gets short of breath, if they're breathing a little bit quicker, I've had a toddler come in, parents, breathing 50, 60 times a minute, and they always been breathing like this for a couple of days. If your child has a fever, or if they're complaining about abdominal pain, and we'll talk about that a little bit more in a second. And these are generally things I want to know about when they're relapsing or right after they have presented. So when that protein is high and when you're starting to see some swelling. So infections are a big deal in children with nephrotic syndrome. And as we talked in the beginning, there's that protein or that albumin that they leak in their urine when they're actively presenting or actively relapsing. Well, that's not the only thing they leak. They leak other proteins, and some of those proteins are what help you fight off infections and deal with a certain type of bacteria that has a capsule around it. And that bacteria is called Streptococcus pneumoniae. And so what happens is, imagine that big swollen belly of that child I showed in the beginning. Inside that belly, it's nice and warm. It's loaded with all this protein, and this particular bacteria loves that. And so they can develop a thing called acute peritonitis, or what we call spontaneous bacterial peritonitis. It's primarily caused by this bacteria, and it can be deadly. And I've seen that. We don't see it as much as we used to. Most of your children now have been immunized with Prevnar. There was Prevnar 7, now there's Prevnar 13. And all children should not only be immunized with that, but they need this additional immunization called Pneumovax or pneumococcal. It's a pneumococcal 23 bacteria. It provides greater coverage for all these different strains that can lead to this. When I initially started training, we used to see this all the time. I infrequently see it now, but it does still occur. Similarly, these legs are swollen. You can imagine your grandparents, what I tell families, the old lady legs. Not that old men don't get them either, but I call them the old lady legs. And there's stasis and things aren't returning. If they get a little cut or scrape, they can sometimes get a cellulitis. Rarely we can see sepsis, which is a bloodstream infection. Meningitis, which is an infection of the lining of the spinal column in the brain. Rarely see that. Urinary tract infection is uncommon. And then chickenpox can be very serious in a child with nephrotic syndrome on presentation or relapse. So that's why we want them to have their Varivax vaccine. By and far, this is the one that I have seen the most and be the most serious. So I tell families, if during this period of time when your child is presenting or they're having a relapse and they have belly pain, I want to know about it. It may be nothing. Maybe they're constipated. Maybe they got a little bit of heartburn, but I want to know about them having an infection. If you press on their belly and let go really fast and it hurts, that's a sign. If you're driving down the street and you hit a bump and they scream, that's a sign of the irritation of that lining around their abdominal cavity. And so that your nephrologist is going to want to know that. Along with the losing of those proteins that help you fight off infections, you also lose proteins that help you not clot. And I don't need to tell you exactly which one of those they are, but those clots can occur in your lower leg, which is called a deep vein thrombosis. Sometimes kids who have had IVs in place can get blood clots around as a result of the IV. Unusual, but can occur. They can get a blood clot in the vein leading out of their kidney. That's called renal vein thrombosis. Those children tend to have belly pain or kind of flank pain. Will have visible blood in their urine. Sorry, that's what macroscopic hematuria is, visible blood in their urine. And they can have some degree of kidney failure. Not common. I've only seen this a couple times in all my years, but it is worth knowing about. And then rarely there can be a central nervous system thrombosis, which again, I have never seen, but it certainly has been reported. This is one of those things that you're hearing about with one of the vaccines at the moment, rare complication. to talk and to go back just a second, not only are those things evident in patients on presentation or with relapses, the people who are not responding well to therapy and are on medications a lot, we can see that as well. So to talk a little bit about the prognosis of nephrotic syndrome, so by and far, a child's or adult's response to steroid is the most important prognostic factor. Regardless if we were to biopsy anybody, if you've got any of those 6 or 7 things that I showed you, if you're steroid sensitive, that's the best news you could get because they have the best prognosis. Unfortunately, some of those will eventually evolve over into FSGS, and I cannot tell you how to predict who those are going to be. And steroid sensitivity, the complication rate with that population is much less than it is for those that are steroid resistant or on the frequent relapser. But again, with some of the newer medications we have, they have nearly not as many relapses as they do otherwise. I feel like I just need to mention a little bit about recurrence after kidney transplant. It occurs in about 30% of patients who have FSGS who go on to need a kidney transplant. It seems to have a higher incidence, and particularly those patients that have primary FSGS, so not those adaptive or those other causes that we talked about, or the genetic causes. If they had childhood onset, if they had a pretty rapid progression within their childhood of going into kidney failure, if they're white, and particularly if they've had recurrence of a prior transplant, the chances are much greater. I wanted to talk just a second about clinical trials because I know NephCure really pushes this and we push this as well. And I just wanted to give you a little bit of idea of what some of these words mean. So there are things called, and many of you are probably involved or your children are involved in these studies already. There are things that are called observational studies. And if you're in Neptune, if you're in a Neptune study, if you're in CureGN, or if you're in one of the kidney research networks, observational means they're just collecting data and they're watching over time how things happen. They're looking for how different medications and how you're responding and biopsy results. And they're not intervening with any type of therapy, but they're just kind of watching and seeing how things go. And as a result of that, then some other studies can come in to be applied to these groups. And then if you look on, I've got the next slide to give you a little bit of, if you look on some of the clinicaltrials.gov or on some of NephCure's sites, you'll see that there are studies, particularly with drugs. So there's phase 1. So this is going to be a very small population of patients, maybe 20 to 80 patients who they're going to evaluate a drug in and go to the highest dose that they can where there aren't side effects for families for patients. So a very small study looking at safety and looking at tolerability. Phase 2 trials, or they're going to go with that dose that they found to be the safest, and they're going to expand it to maybe several hundred patients and see if there's anything that comes out as a result of that. And that may go on for several months to a year or more. And then you might see something about phase 3 trials. And phase 3 trials is they're taking that medicine and they may use separate doses, and then they're going to compare it to something else. And those are often maybe thousands of patients, 3,000, 4,000 patients, maybe not so much in pediatrics because it's what we deal with is so rare that usually the numbers are much lower in the pediatric trials as opposed to the adult trials. And they're going to, sometimes you'll see something that says randomized trial, where people are going to go, they're going to select randomly. No one knows who is. This patient will go in this trial or this arm, and this patient will go in this arm. And they'll look at how they're doing in comparison to one another over time. And then at any point where if it looks like one group is exceedingly doing much, much, much better than others, sometimes they'll close the trial. And because you're using many more patients, it's easier to look for the effects and side effects. And then phase 4, if you were to see something like that, that means that the FDA has already approved that drug, and they're now watching it long-term to see if there's any complications that could have come about later on. And then lastly, these are just some resources that you can go to. There's clinicaltrials.gov that will list all trials that may be pertinent to adults, pediatrics, certain disease states. Obviously, the Gateway Initiative is very involved in research around nephrotic syndrome, so you can go to their site and look. And then this is another site that you can go and look for clinical trials to see whether or not you're eligible or not. Unfortunately, most clinical trials are 18 and older, which is very frustrating to those of us in the pediatric world. There is much excitement though, and many more trials now, not many, some trials now are going down to age 12. We've got a couple of trials that are going down to 5, and there's a new one that we're going to be involved soon that's going to go down to 2, which is very exciting. I say all the time, I hate that your child has to wait 5, 10, 18 years to be eligible for a trial with a disease that maybe we could have done something with a long time ago, and given all the medication complications that we have. This is a thank you for the sponsors of the summit today, which it couldn't have occurred without them. And then I've given you 10 minutes.
I know.
Perfect.
Thank you so much, Dr. Massengill. You were so worried about running out before the time ended, but we actually are out of time. So what we're actually going to do, if you're okay with it, for anyone that has questions, we're going to, or follow-up questions, we're going to direct them to Kelly, and what we'll do is send them to you after this.
Okay.
And then that way we'll send them back out to everyone. But the chat function will be open for a few more minutes. But thank you again, Dr. Massengill, for joining us today and providing us with such great insight for our patient families.
And stay hopeful.